All right. Good afternoon, everyone. And I'd like to welcome you to our special Thursday noon conference. I'd like to welcome Dr. Ahmad Masri, who is an assistant professor of medicine at Oregon Health and Science University. Dr. Masri is a cardiologist who specializes in cardiac imaging, hypertrophic cardiomyopathy, and amyloidosis. He directs the Center for Hypertrophic Cardiomyopathy and co-directs the Center for Amyloidosis. He's trained in internal medicine at the Cleveland Clinic, completed training in cardiovascular disease at the University of Pittsburgh, and then spent 2 years at the University of Pittsburgh, supported by a grant from the National Institute of Health, focusing on cardiac imaging and left ventricular hypertrophy. Welcome, Dr. Masri, and thank you for being with us today.
Fantastic. Thank you, Nadeen. Thanks for the kind introduction and for the invite here to speak to you today. It's a pleasure joining you. Let me see if this works. Okay, good. So those are my disclosures. I receive research grants all paid to HSU, and I will be discussing mavacamten and CK-274, which are not FDA approved. And for those of you who don't know, it's this like being back in residency and actually, being back home. All of these individuals have been either co-residents or senior residents to myself, or junior residents, and it's really great pleasure being here. I'm sorry if I forgot anyone, but also there are a lot of friends and mentors who are currently at Methodist, so it's really truly an honor speaking to you today. And so I know we have a mixed audience here, so I thought I would just really try to target both some material for our fellows, as well as some new exciting developments and why I'm excited about HCM. So the outline is the first part. We'll talk about the old stuff that a lot of you know, and then spend some time talking about the new things in hypertrophic cardiomyopathy. This is a timeline here, just showing you, how mature the disease is, as well as the innovation and advance that happened over the years, dating back to 1957-58, where the first case series was described, up until when surgical myectomy was actually, performed and by Dr. Morrow over there, as well as Dr. Brunewald, where he described all the hemodynamics of hypertrophic cardiomyopathy and why it's different from aortic stenosis and sub-aortic stenosis. And we, continue there all the way with echo development, MRI development, ICDs, all the way up to when we're right now in really exciting times where we have newer therapies for hypertrophic cardiomyopathy, which I will be discussing in details. Hopefully the videos are playing. I know that sometimes they come across over virtually, not, chopping a little bit, but really when you think about HCM, we think about thick walls, non-dilated left ventricle, hypercontractile or hyperdynamic function. No other clear reason for left ventricular hypertrophy. And always remember that we are ought to rule out phenomimics of it, because if we don't think about them, although they're uncommon, we tend to miss them. And so this is where you see here asymmetrical hypertrophy of the anterior septum here compared to infralateral wall, and here you see SAM, systolic anterior motion of the mitral valve. And this is a classic, essentially, phenotype for obstructive hypertrophic cardiomyopathy. And here you can see that what we call here the classic Y sign, where you have essentially LVOT acceleration or obstruction, as well as mitral regurgitation that is related to SAM, and that is over there posterior directed. Strain imaging can help sometimes. You would have essentially decreased strain at the bases, at the anterior septum specifically. And not to forget the other type, which is more often actually missed, which is non-obstructive hypertrophic cardiomyopathy, where you have essentially thickening in the heart without any other reason, but there is no SAM, there is no obstruction in the LVOT. And so when you think about it from a histopathological perspective, this is the classic description where you have the normal architecture of the nucleated myocytes there. And with classic hypertrophic cardiomyopathy on histopathology, you have disorganized myocyte disarray. And when on gross specimen, you have fibrosis, which we can see is replacing in the interstitium there. But this is not this is not found universally. That's why biopsy is not something that we typically do to diagnose hypertrophic cardiomyopathy. Myocyte disarray is not a universal finding in such patients. And this slide is from my friend and mentor, Steve Heitner, where if you think about how many mutations we have in HCM, there are a lot of mutations, more than 1,400, 1,500 described today. The majority of them are in the myosin binding protein C and in the myosin heavy chain. So what we call heavy chain disease or mutations. And then you have a lot of other dispersed mutations in the thin filaments, in the troponins and tropomyosins, and a slew of other mutations. And the way to think about it, I love this depiction here by Steve, where he thinks about cardiac myosin binding protein C being the brakes, and then your myosin being the gas. And any mutation in either of these genes would lead essentially to the phenotype that we see with hypertrophic cardiomyopathy. Again, I'm sorry if the videos are not playing well, but genetic testing yield relates directly to the phenotype itself. And when we think about HCM, the majority of patients have sigmoidal shaped septum. Some of them, all of them also have reverse curvature. And we see, quite often here we see apical HCM as well as the neutral phenotype there. And when we run genetic testing, and this has been published on before by many groups, the overall yield so far is about 40, 50%. It's the same here at OHSU. And we see it commonly that apical is almost all the time is, we don't find really genetic mutations. Same for neutral. But when we come to reverse curvature or sigmoidal, we have more luck typically there. And it's very, very common to have patients who are the first ones diagnosed in the family. Not to forget the mitral valve. The mitral valve in HCM plays a very important role. SAM is the hallmark of the disease, where you have obstruction in the LVOT for the blood flow trying to leave the ventricle, leading to wall stress and a lot of slew of other problems. But also don't forget that there are a lot of elderly patients with HCM. MAC creates a special problem, especially for those being considered for surgery. You have elongation of the leaflets, which we see a lot on MRI imaging that by themselves can cause problems. We've had cases as well as others of obstruction without significant hypertrophy. And also abnormal papillary muscle is increasingly recognized in the era of cardiac MRI imaging as being a very common problem and encounter in patients with hypertrophic cardiomyopathy. Again, besides the mitral valve, we have the submitral valve apparatus to think about. These are two different patients where you see the papillary muscle is being slightly displaced there, but more importantly, its insertion is anomalous. Instead of inserting at the tips of the leaflets, they're inserting closer to the base. Here, the ventricle is dilated, so it's not causing obstruction, but that's unfortunately a bit late. While here, you can see how this patient had a high gradient and there was no SAM. The gradient was secondary to the papillary muscle insertion, where it is inserting at the base of the anterior leaflet. A very important distinction there is hypertrophic cardiomyopathy versus athlete heart. And there are a lot of features that can differentiate both of them. The most important things to remember, especially for our fellows, is when we talk about this, we're talking about a gray zone. We're not talking about someone who has a 2 centimeter heart, septum, and we're discussing athlete heart. The majority of athlete hearts essentially don't really go beyond 15 millimeter or so, 16 millimeter in thickness. And so when we talk also about athlete heart, we have to remember that the LV cavity is typically not necessarily dilated, but it is generous. While in HCM, the LV cavity is typically small. As well as whenever you have any diastolic dysfunction, any abnormalities there or marked left atrial enlargement, abnormal LV filling, think about HCM obviously and not athlete heart. With athlete hearts, typically you have some thickening, you have some enlarged ventricle, but otherwise everything else appears to be normal. And when we think about the presentation, there are a lot of buckets there. And the buckets can essentially move the patient from completely asymptomatic, even not having the phenotype, but just being genotype positive, to even being at high risk of sudden death. And sudden death does not always correlate with symptoms. It can be the first presentation in some patients. The most a troubling development for patients with hypertrophic cardiomyopathy, besides essentially sudden death, which can be a final event, is heart failure and atrial fibrillation, and those create a lot of morbidity for patients. And we'll talk about where mortality for these patients nowadays are sitting. And so when you think about features of it in the clinic, even without talking about imaging, this is one of the hallmarks of apical HCM Yamagashi type EKG, where you have deep T wave inversions, high QRS voltages there. And we've actually written a case about this one time in one of the electrophysiology books, where patient with this pattern, with history of hypertension on a couple of medications, kept being told that this is because of high blood pressure, until essentially, unfortunately, they are arrested and couldn't be revived. And so this is a very important pattern to remember also for the boards. But really the hallmark of the disease when in obstructive hypertrophic cardiomyopathy is the fact that it's a dynamic process. Anything that alters LV cavity volume or contractility and afterload would lead to either increasing or decreasing of the murmur. The most common things we do in the clinic are Valsalva, standing while essentially having your stethoscope on the patient, as well as you can do hand grip and squatting maneuvers to see essentially how the murmur changes, and you can compare that to murmurs of mitral regurgitation. And this is essentially, if we are going to move to the imaging space with echocardiography, you can really study these patients' hemodynamics very carefully. Here is the LVOT gradient at rest. You can see where the velocity of the wave is, while when Valsalva starts, there is more dynamic LVOT obstruction, mainly because of SAM in this case. And then once patient stops the Valsalva and the intrathoracic pressure goes back to where it was before, they go back to where the gradient was at rest. And so when we think about how do we manage these patients, we broadly classify them into those with obstruction and those without obstruction. Unfortunately, patients without obstruction right now, we don't have a lot of good therapies for. We try beta blockers, calcium channel blockers in them, as well as, if they have decreased ejection fraction, we try standard of care therapies for any heart failure patients. We also rely a lot in diuretics in these patients if they continue to have issues despite being on beta blockers or calcium channel blockers. But besides that, we are limited. There was a phase 2 Maverick study of mavacamten in these patients to show the signal for benefit there, and then we will be probably moving for the phase 3 in the next couple of maybe next year or so. But focusing on the a hallmark of hypertrophic cardiomyopathy, LVOT obstruction, you always start with either beta blocker, calcium channel blocker. If you look at the guidelines, typically you go with a beta blocker first. What we notice is that in young patients, they really don't tolerate beta blockers, and they almost always ask for a switch. And so we typically start with the calcium channel blockers in younger individuals. And in our practice, if those fail, we actually do try disopyramid. And I'll show you later on some data on diso in our practice. If it works, it works. But the majority of the time, there are either intolerable side effects or it's not working enough for what the patients want. And so if medical therapies fail, then we move towards invasive therapies, septal reduction therapies, including septal myectomy, with or without interventions on the mitral valve papillary muscle and alcohol septal ablation. I will not be discussing really the performance of septal myectomy against alcohol septal ablation. There are a lot of papers out there discussing this, a lot of talks discussing this, but we will focus more on what's new in hypertrophic cardiomyopathy. Looking at disopyramid, this is from Dr. Shured and colleagues, multi-center study of disopyramid showing that over time, the outflow gradient dropped from around mean of 80 down to about mean of 40, and patient symptoms obviously improved. There are figures in that paper showing freedom from all cardiac death and sudden death. It's hard, patients who are left with obstructive disease do tend to do worse, obviously, but we typically don't really do that. Typically nowadays, patients who have symptoms, we do try to treat them aggressively as much as we are able to, up to the point where we offer them septal reduction therapy. So we don't really leave patients obstructed for a long period of time. When we talk about septal myectomy, the outcomes are excellent, but these outcomes are at centers of excellence or high volume myectomy centers. And when you compare it to non-operated obstructed patients, obviously the outcomes are much different. And that's why septal myectomy is an excellent procedure. Recovery typically is actually relatively short, and the mortality should be less than 1% if done with a high volume surgeon in a multidisciplinary approach situation. When we talk about alcohol septal ablation, it's a very enticing alternative to septal myectomy and or even potentially lifelong medications for some patients. However, there is not always consistency. You can't always predict how the outcome would be. This is a study from Dr. Naga from Methodist and colleagues who looked at accrued survival in about 800 patients or so after doing alcohol septal ablation, and you can see that the survival at 3 years is approaches 97, 93%, but then drops down to 74% at over 9 year period. We really cannot compare this to the survival after myectomy because of selection bias. We all know, including in our center, that we select patients for alcohol septal ablation who are not candidates for septal myectomy. So the prototype by itself is already different. So comparing them is a tricky approach. When we think about HCM, again, that's why HCM is partly famous because of the sudden cardiac death that happens and can be the first presentation, especially in young individuals. Those are the three current models we use to estimate risk in HCM. The good news is the majority of the patients have low risk for sudden cardiac death, and that's why we have somewhat conservative approach when we implant ICDs in patients. The 2011 ACC/HA guidelines, they're due for an update. Hopefully, we'll see something either this year or next year. The classic risk factors that almost everybody essentially have heard about at this point. They're going to be potentially, revising the role of these potential modifiers, including LGE on CMR, having an apical aneurysm, marked LVT obstruction. In Europe, there's different approach. It's an, mathematical approach where you essentially include your LA diameter, wall thickness, LVOT gradient in the equation there, and you have risk categories. That was internally and externally validated, but there are some prelim data from Dr. Maron and his group showing that potentially, as well as Dr. Desai, showing that potentially that this might not be performing as well as we think it is. And finally, Dr. Maron recently published what they call an enhanced ACC/HA risk model by including some of the modifiers we have already discussed there. Really, my own belief, as well as a lot of the literature that is out there, including our current practice, is that unless contraindicated, everybody with HCM should get a cardiac MRI. One, for risk stratification for sudden death. You would be surprised sometimes how the amount of fibrosis you find, as well as surprised when you find no fibrosis despite having severe LVH. The second reason, I think, which is even sometimes can be more important, is ruling out these other phenotypics of disease and really deeply studying what's happening with the submitral valve apparatus in these patients. HCMR is led by Dr. Neubauer and Dr. Kramer, a multi-center study, NIH sponsored, finished enrollment a while ago, 2,700 patients. And we will learn a lot because of this trial. This paper came out last year describing the study population. As you can see, there are two broad, relatively distinct populations there, those with sarcomeric mutations and those without, and they're very different from each other. But what I want to draw your attention for is there is a tendency to overcall LGE in HCM patients, especially in areas where they have, where they're not experienced in essentially evaluating this. And, the HCMR showed us that. Granted, these are patients who don't have devices, but if you look at this, only 1% of the patients had more than 15% LGE quantified, and 1% had 10 to 15%. The rest had lower than that, and almost half the patients had no LGE whatsoever. So keep that in mind, and don't be discouraged when you're getting CMR in patients and most of them don't show LGE there. Remember, ruling out phenotypics is a very important reason to get MRIs. And again, I apologize if this is not projecting well, but this is one of the most important reasons I see for getting CMR, especially in apical HCM. This is a patient, an elderly patient who had a lot of heart failure with ejection fraction admissions and was called to have apical HCM. But then when you perform the CMR, I mean, you're not seeing the thickness. I can tell you that not in any segment, she did not have more than 11, 12 millimeter thickness in her LV, but she had her apical muscles displaced, occupying the apex there. And what I'm not showing you is on the short axis, the apex completely thins down without any issues. So unlikely to be true, at least in the true sense of apical HCM, how we think about it. The other reason is to have a multidisciplinary approach to this, as well as really a careful approach to HCM, is that you will be surprised with what you find, and you will be surprised with how many patients carry HCM diagnosis for years and years and years until someone else looks at the pictures and goes like, huh, there's something that doesn't make sense here. This is a story of a patient new to us, 54, completely asymptomatic at the time, like a year prior to presentation to us, healthy, athletic, no family history of heart disease whatsoever, had a syncope a year before, was diagnosed with HCM, and had an MRI done with LGE and CNA imaging, got an ICD implanted because of syncope, and was told that his cardiomyopathy genetic panel was inconclusive or negative. And so when he presented to us, just because he looked us up online, and presented to us for kind of a quote unquote second opinion, or more or less for a formal evaluation at an HCM center, we looked at this echo here, and again, apologize if it's not projecting well for you. There was kind of a asymmetrical hypertrophy. The upper septum is actually relatively thinner, much thinner compared to the mid septum. And then also the inferior wall is thick. And no matter what we did with the patient, exercising him, and he exercised very well, you really couldn't elicit much SAM. It's more or less all related to a papillary muscle here, causing the gradient. And as you can see, post exercise, he had some gradient, obstructive gradient, that wasn't present before exercise, but also its shape is not your classical dagger shape, late gradient there. And so, overall, we were like, he has a device. We typically don't do repeat CMRs in people who have devices. But at least I wanted to actually make sure that I see the genetic panel that was negative. So we obtained that, and it took some time to get that. And to our surprise, he had a GLA, a gene mutation in a very conservative mutation that typically present late in older males, and typically can have an isolated presentation. If you recall Fabry disease, where you have kind of a sphingolipid accumulation in the heart, in males it typically presents early, and the disease have a lot more symptoms besides having cardiac symptoms. And so this reiterates our practice, where we insist all the time to review all of these reports from the source documentation, as well as review the pictures. And so the patient was started on chaperone therapy, oral therapy, and things are going well there. Another example is this is a 52-year-old woman who has had dyspnea for a long time with NYHA class 2, recent worsening to NYHA class 3. She's been diagnosed with obstructive HCM for a while, was in metoprolol for a while. But then when you look at her imaging, it really doesn't make a lot of sense. And you're like, there could be something else going on. You see some calcification here, or like high echo signal intensity there. It's not uncommon in HCM to have injury in the basal septum over there from high jet lesion over time, but also the thickness in the inferolateral wall, and down there not much at the septum, how the shape of the LVOT gradient at rest. This is GDV, is goal directed Valsalva. We make our patients actually blow into a manometer to achieve 40 millimeters mercury at the manometer, so that we bring out the gradient more and ensure that Valsalva is kind of a protocolized. And so after that, hopefully you can see the TEE pictures here. We met the patient and we're like, well, this looks really like could be something else, including like a partial membrane, and which was the case. You can see here that there is this incomplete something hanging over there. And the main differential for this is having a papillary muscle directly attaching over to the basal anteroseptum, but this wasn't the case. This is essentially was a membrane here. And so patient, of course, was referred for surgery. And not to forget atrial fibrillation, very important in patients with HCM. It's very commonly symptomatic. We typically treat it with rhythm control strategies, just because the patients do not tolerate it very well. And remember, don't use CHADS FAST to decide on anticoagulation. All patients universally should be anticoagulated if they have AFib, unless there's a big contraindication. And this has been shown by 3 large studies from large databases in Asia, showing how the incidence of stroke was common irrespective of CHADS FAST. And there are a couple of papers here and down there, meta-analysis showing you how AFib essentially contributes towards survival in these patients. That doesn't mean that treating AFib with rhythm control would lead to essentially improved outcomes in terms of mortality, but we see it every day that patients feel much different when they're out of AFib just because of the underlying disease that they have. Now, shifting gears to discuss about the new developments in HCM. And when I say new, this has been ongoing for 5 to 10 years now, but there are new trial and recent findings that are very exciting. So why are we talking about new things in HCM? Again, this is a disease that's been worked on for 50, 60 years now. Somewhat we have a mature understanding of the pathophysiology underlying it. But in terms of treatment, we really haven't had any recent successes there. Numerous small RCTs, I counted 13 in the last 10 years. Most were neutral, and none of the current standard of care therapies underwent evaluation by a contemporary randomized clinical trial. And finally, if we're saying that outcomes in HCM are good, you're trying to evaluate sometimes non-objective or soft endpoints. You really need blinding for that to be sure of what you find there. Unlike you, I never thought that I would come back to this after medical school, but life happens and things change and interests change. This is the mechanochemical cycle of myosin and actin interaction. Instead of thinking about it like we used to think about it in medical school, think about it in the terms of how the sarcomere scientists think about it. Is that you have this is red essentially, and yellow there are myosin heads, and then this is actin, and you have binding, strong states of binding there, and you have weak states of binding there. And depending on where you are in the cycle, that determines your contractility of the ventricle. If you are in the weak proportion there, you want to do something for the sarcomere to make it be, contract better. That's what omecamtiv mecarbil does. And then if you are on the have a mutation where you are on the hypercontractility aspect of things, you want something to essentially prevent that from happening. This is a video that was published back in the 1990s, but I think it nicely explains how ATP comes and bites on the myosin head there in order to promote the disengagement from actin, and then the power stroke to happen. And that's how essentially the sliding of actin and myosin happens through the release of phosphorus, and then you're left with ADP that you need to get rid of for the cycle to repeat itself. And so when you think about it, since there is hypercontractility in HCM, if I target this, can I actually treat patients? And that's the basis for all these newer developments that we'll be discussing. So when we think about mechanism of action for some of these cardiac myosin inhibitors, right now we have 2 agents, mavacamten, which finished phase 3 trials, and we have CK-274, which is now currently undergoing phase 2 trial. Normally, 40% of the myosin heads are folded back into something called super relaxed state, or SRX, and they're not available to engage in actin myosin cross bridging. And so you have free heads, you have blocked heads there, and that state is dynamic. But in most normal humans, a lot of myosin is not available. When we think about what happens in mutations, this is, for example, a mouse model of a mutation in MYH7 gene, where you have really very low amount of super relaxed state of myosin. So you have more availability for engagement, which leads to hypercontractility. For the same mouse model, when treated with MAVA, you have increased in the number of the percentage of your myosin heads that are super relaxed. So you're trying to bring these patients back to a normal state by inhibiting that hypercontractility from happening. And when you think about the volume pressure loops, this is volume here down there, and LV pressure on the y-axis. Mavacamten leads to shifting of your loop to which improves compliance and as well as decreased contractility. And so that is the benefit that we see in patients when we use it as a negative inotrope that is specific for the sarcomere there. This is a mouse model, again, of alpha-myosin heavy chain. When the mouse model was treated with MAVA, it prevented hypertrophy, prevented altered gene expression, decreased fibrosis area that we saw in the mouse models, reduced myocyte disarray. This is pretty amazing to witness that, where you have untreated the untreated essentially mouse had all this disarray there for their myocytes, while the treated ones continue to have normal looking without myocyte disarray. And this is just showing you the trajectory of how the summation of the direction of these myocytes look like. Then after phase 1 and finding the exact dose that we needed for mavacamten, Pioneer HCM was conducted. And it was a phase 2 trial, open label. It wasn't a blinded, but it had two cohorts. Cohort A, which had 10 to 15 milligram dosing, and cohort B, of course, as a starting dose, and cohort B, which had 2 to 5 milligrams, 2 as a starting dose. And the trial was run over about 16 weeks. There was a washout period there, and you can see how we know there was a lot of echo assessments, because you need to know what is the drug is doing. And if you think about it, what is the downside of doing so? If I'm pushing patients from the hypercontractile, or maybe a little bit hypercontractile state for them, I'm pushing them to the weaker state of contraction there, then if you overdo it, you are at risk of causing systolic dysfunction. And so that's why it's a fine balance, and we need to understand which dose we need to use, how we need to monitor these patients. This was published last year in the Annals of Internal Medicine, led by Dr. Steve Heitner and his colleagues, showing how mavacamten was effective and in abolishing the LVOT gradient, while generally speaking maintaining reasonable LV ejection fraction. Remember, there were two cohorts. Cohort A, higher dose, 10 to 15, 10 to 20, sorry. Cohort B, 2 to 5, and 2 to 5 there. And on this y-axis, you have LVOT gradient, and you can see from the start of the study, the peak gradient went down from the hundreds range down all the way here to less than 20. And also you have post-exercise gradient going down. While with the LV ejection fraction, there was a decrease there in about 14% decrease in ejection fraction, absolute decrease there. While in cohort B, there was also decrease in LVEF. However, because you're using a lower dose, LVOT gradient did decrease, but not by as much as it was for the higher dose. And so you really need to find that sweet spot where you can abolish the gradient but maintaining systolic function at the same time. And so this led to the design of the phase 3 Explorer HCM trial, where it was a trial of about 250 patients. It was done over 30 weeks with an 8-week washout period. And then patients after that, by choice, chose to enroll into a long-term extension study. Everybody started at 5 milligrams and had two opportunities to titrate at 8 weeks and 14 weeks. The rationale behind this titration scheme is the fact that mavacamten half-life is long. So we're talking about long being in the order of 2 weeks or more, depending on the metabolization state for the patient. And so you had the patients who were randomized to MAVA or placebo in a double-blinded fashion. And echoes were assessed by a core lab there. And so when you think about the patients we enrolled patients who were well treated on standard of care therapies, beta blockers, calcium channel blockers, and we enrolled symptomatic obstructive patients. The majority of them had NYHA class 2, and the rest had NYHA class 3. Why is this important? It's important because this seminal paper by Dr. Marin showed us that if you don't have obstruction, your outcome is better than if you have obstruction. And if you have obstruction and asymptomatic, your outcome is better than being symptomatic. The other thing that was part of the trial is that these patients had abnormal biomarkers, NT-proBNP, as well as high-sensitivity troponin. And again, this is pertinent because many studies out there, I chose two to show you here, showed that NT-proBNP as well as high-sensitivity troponin do risk stratify patients and show you that patients with higher biomarkers have worse outcomes. This was the primary outcome of the study. The study approached a co-primary outcome of increase in peak VO2 with improvement in NYHA class, or increase in peak VO2 by 3 or more while NYHA class is no worse. So we hear that, everybody tried to get together and come up with endpoints that make sense in HCM. One is objective, one is somewhat subjective, but assessed by a physician in a blinded fashion. And so, as you can see, mavacamten was able to achieve that primary endpoint in 37% of the patients versus 17 in placebo, with an absolute difference of 19% there. And when we talk about soft endpoints or none, which we are not really used to it in cardiology, this is the reasoning. This is a paper by Dr. Maron showing you with contemporary therapies, the outcome of patients with HCM is really good. And when we talk about trying a medication over 30 weeks or even 2-3 years in HCM, you really are not going to be able to find a signal for death, for example, or transplantation and whatnot. And so the other point being is, why is peak VO2 important? This is a paper, this is one of the first papers I worked on when I was in the Cleveland Clinic with Dr. Melinda Desai, where we showed how peak VO2 in 1,000 patients with HCM really predicts heart events there. And so mavacamten showed us sustained effect on the LVOT gradient. Here you can see this is post-exercise only over 30 weeks with only two occasions where you can uptitrate. The decrease in the mavacamten group was 47 versus 10 in the placebo group. And 74% achieved gradient less than 50 as compared to 21% on placebo. And this while maintaining LV ejection fraction still in the 70s range for the mean. Some reminders here: the echoes were assessed by a core lab. There was quantitative biplane LV measurement. They would reject a plane if they have poor windows and go off of one of the planes. No echocardiographic contrast agent was allowed at the time, which as you can imagine, there was limitations for this. We used fasting LVOT gradient, not postprandial. There are a lot of papers out there, including one of our group, where we show that you really need to use postprandial and potentially use goal-directed Valsalva, not just ask the patient to hold their breath. And finally, the post-exercise gradients were protocolized. However, they were obtained in a fasted state. We obtained it in our patients, in a postprandial state. If you think about NYHA class done in a blinded fashion, aside from peak VO2, 65% of the patients achieved more than one NYHA class improvement as compared to 31 on those on placebo over 30 weeks. And there was a rapid and sustained improvement in markers of wall stress. Patients on mavacamten started with a mean of 777 for NT-proBNP and went all the way down to 163. Really impressive. Early and sustained, similar with high-sensitivity troponin. We don't use this in clinical practice typically, so it's really hard to understand the benefit of this reduction. It's more easier to understand it for NT-proBNP, but more papers will come out, talking about this and its significance. The argument is, we really don't need any new therapies in HCM. Look how awesome people are doing in terms of myectomy, over many, many years of follow-up, as well as with NYHA class after septal myectomy. This is percentage of the time patients are spending in NYHA class 1, 2, 3, and 4. So in general, you can make the argument that it's one and done. Let's do the surgery and move on for obstructive patients. But there is more to the story. This is by Dr. Ho and colleagues from the SHARE registry, showing us that in patients with HCM, and this is including different types of HCM, but in general, take the point that their outcomes are worse than the general US population. And as you can see here, the red essentially depicts HCM and incidence of death, while the US population is down here for age-matched subjects. And so there is a signal that we actually might need to revise this idea that myectomy solves all the problems for patients with HCM, especially not everyone qualifies for myectomy or alcohol septal ablation, and even some of the patients, not everybody benefits necessarily there. And the rest of the world does too. Not everyone has access to a high volume myectomy surgeon center of excellence where you're able to essentially just refer the patient and get the surgery done, or even an experience center for alcohol septal ablation. I know, for example, I am, where I grew up, I know a lot of people who were able to afford travel, used to travel to Germany to get alcohol septal ablation. And even that wasn't cheap. We're talking about the order of $40,000. And so that's one of the reasons to discuss why we need new therapies in HCM. Another important paper in JAMA Cardiology published in 2016, this is the reality of everyday practice. 60% of hospitals in the United States perform less than 10 septal myectomies. The mortality in the lowest tertile volume was 15%. We're talking about a surgery that we advertise everywhere that the mortality is less than 1%. And it's true, I've seen this in many of the centers I've been in, including ours, that the mortality is exceedingly rare. But this is for surgeons who average one myectomy every week or two, as well as when you have multidisciplinary approach to imaging, to evaluating which patients should go which route there. And so the way I think about this, modifying anatomy versus targeting pathobiology. This is the story of success in medicine and progress in medicine. Just giving you some minor examples. I know we can, debate these all day long, but this is just some examples. Coronary artery disease in the 70s and 80s, everyone was getting cabbage. Now we're talking about medication first. Gastric ulcers and DU ulcers secondary to H. pylori. Everybody was getting gastrectomy. That was what all general surgeons did back in the 70s and 80s, but now we are treating them with antibiotics. And I propose this. We actually don't know the answer to it, but HCM, when it's obstructive and continue to have symptoms despite medical therapy, this is our default treatment. Could myosin inhibitors replace that approach or be better than that approach? We'll find out in the future. We still don't know. When we talk about peak VO2, the question is, was this really important? Improving peak VO2 by 1.4 in mavacamten compared to no change in placebo? I can tell you that changing peak VO2 in heart failure and heart failure trials have been a very challenging point to achieve. And there are reasons behind why this happened, and I'll discuss it shortly here. But if you think about other trials, Steve Heitner, who essentially was led the pioneer HCM, in the cohort A where no beta blockers were allowed, they achieved 3.5 change in peak VO2. Sarah Saberi from Michigan, as well as her colleagues, looked at exercise in HCM, and they were able to show an increase by 1.3 there in a regimented exercise program. 17% were obstructive HCM patients. And then this is a study of 1,600 patients with HFrEF where an exercise regimen was done and peak VO2 changed only by 0.4. So these numbers, which are done after myectomy and alcohol septal ablation, were small series long time ago, and we need to reevaluate how we think about this now in other studies. But I can, this makes the argument that the 1.4 change is not that minor. The other point to make is looking at beta blockers and thinking beyond the forest plots. When you think about this, why do we do subgrouping and forest plots in patients in clinical trials? We're trying to see where the trend is. These trials are not powered to detect the difference there so that it doesn't cross the confidence interval. So this is on this side showing that mavacamten was better, and this side showing that placebo was better. And when you first look at it, they're like, maybe the beta blocker usage actually attenuates the effect of mavacamten. There is no biological mechanism to think that this is the case. There is an actual reason for that. If you remember, the primary outcome was what? Was peak VO2 and NYHA class. So when you look at what happened in NYHA class, it was the same exact improvement in those on beta blockers and not on beta blockers. However, when we think about the mean peak heart rate with exercise, peak VO2 is reliant on heart rate, and it's a measure that relies on it. So when you blunt your heart rate with a beta blocker, your peak VO2 would be lower. And there is a lot of literature published on the effect of beta blockers on peak VO2. If you look at the mean peak VO2 change on patients on beta blockers was 1.1 and mavacamten, while not on beta blocker but mavacamten was 2.2, almost double. And then finally, there are other measures in CPET that are not related to beta blockers, which are minute ventilation over CO2 production, which showed that the change in slope is similar. And there are studies showing that the change in slope there is important and relates to outcomes in heart failure. I would make the same argument for genetic testing results, that in general, the direction is in the direction we would want. Crossing the confidence interval there, crossing the 0 point is not discouraging because these are not, the trials were not powered for this. And another reassuring point is that the effect on LVOT gradient is consistent across all subgroups, even those without a genetic mutation and those on beta blockers. And so when I think about Explorer, I think about it being the first pivotal phase 3 trial for a new class of medication. And so you really need to balance safety and efficacy. If you think back to Pioneer, I showed you the difference in gradient was 90, and the difference in LVEF was 14%. In Explorer, it was a more conservative trial. The difference was 47 millimeters mercury, and then the difference in EF was about 3.9%. Granted that Pioneer was open label, small numbers, less precision, but it shows you the potential performance of those medications if we can find a way to be more aggressive but also safe at the same time. This is very important. Results from the trial showing who had an ejection fraction less than 50%. Only 3 patients on mavacamten during the trial suffered lower ejection fraction than 50%, while the rest had it discovered by the end of the study at 30 weeks. What's important here is that there is a dissociation or discordance between biomarkers of NT-proBNP, NYHA class, LVEF, and efficacy assessment. Only 1 patient had concordant improvement in KCCQ, peak VO2, and decrease in biomarkers. Everybody else had essentially discordant measurements. And so that tells us something. We actually are measuring something that might not be what we think we're measuring. What does that mean? When we think about LVEF in HCM, when it's less than 50, it is scary. Run away. You don't want to let patients go to less than 50% of ejection fraction or just simply having systolic dysfunction because the natural history is not good. This is freedom from death and transplant or LVAD, and this is showing us what patients do when they have systolic dysfunction or termed in the stage with reduced ejection fraction. Really, their outcomes are poor. So everybody gets scared when we look at this. In myosin inhibition, there appears to be a different story there. Having EF less than 50% appears to be reversible in the majority of patients. It's typically asymptomatic. There might be delayed and continued remodeling. And so when we do real world titration, we are actually not going to be as quick probably as the clinical trials are. We're going to wait and see how patients do. We're going to maybe essentially decide differently on how we titrate medications. And then we really need shorter formulations, meaning if a patient goes and develops systolic dysfunction, we don't really want to wait for weeks and weeks and weeks before that formulation washes out of their body. And a lot of more data are being generated by 2 open label studies from Explorer as well as from Pioneer. And there is the ongoing Redwood and HCM testing CK274 as well as phase 3 plan. And then we have Valor HCM also for mavacamten. What about disopyramid? I think we're a bit short on time, so I'll run quickly through this. So diso is a good medication. You try it. Patients will tell you very quickly if they feel good or not, if they have side effects or not. But about half of the patients either have side effects or don't feel complete resolution of their symptoms. And in our experience, this is 125 patients here at OHSU over 4-year period. More than 65% of the patients stopped diso less than 1 year of its prescription. More than half of them stopped it at less than 1 month from the prescription. And only 20% of them stayed on it more than 2 years, unlike the medication without side effects. And so we really cannot say that disopyramid is essentially mavacamten is just an expensive disopyramid. They're a bit different, and the ability to use them and the practicality of using them is different also. What's also different is myosin inhibitors are on target. They target myosin. They don't target calcium currents and intercellular calcium. This is an experiment showing you complete overlap that mavacamten here and CK274 do not affect calcium, while here you can see how disopyramid does affect calcium. This is the design of Valor HCM, which will allow disopyramid, and it will include patients with what termed more severe disease, 100 obstructive patients. It's already enrolling. NYHA class 3 and 4, dynamic LVOT gradient. And disopyramid is allowed. So we'll learn more there. And this is the design of the ongoing Redwood study. We've enrolled a good number of patients here also, 10-week trial, which will show us once unblinded what's happening to patients and how much they're improved there. And the nice thing about this study, it is tested to essentially be sequential. So we'll go from a lower dose to a higher dose and push the limits there, see how far we can go. And just one quick point about what RCTs don't measure. These are real quotes from patients. My life turned around since I started mavacamten. We were at the verge of bankruptcy. I was able to immediately go back to work and save for retirement. And the patient wasn't able to afford any of the SRT therapies that we can offer. Another patient said, immediately I was able to play with my grandkids again. And then a patient said, I'm afraid of procedures, declined SRT despite being short of breath, walking room to room. Now they were asymptomatic. Another patient said, I feel the best I felt in a long time. The caveat being he was on placebo. And so this gives you an idea that qualitative research matters, understanding how patients feel matters, but also there's the caveat that the mind is very powerful. At OHSU, in our center, we right now have about 30 patients on mavacamten, and we're actively enrolling in Redwood HCM, Valor HCM, and then we also have Entresto study in non-obstructive HCM ongoing. And so this is just what I alluded to, that in the absence of high event rate, we really need a drug that addresses the underlying pathological mechanism, make patients feel better, and prevent complications. The question about preventing complications for MAVA is still out there. We'll have to wait until these long-term studies essentially results are obtained and accrued over time. So in conclusion, HCM is a complex disease. Newer therapies are on the horizon. MAVA is effective and appears to be safe in general. And its long half-life, requires careful monitoring and titration. The open label studies ongoing will give us an idea about having on-site read echoes because they're now on-site, not with a core lab. A lot of studies are ongoing, a lot of excitement in the field, and encourage all academically inclined fellows. They really should highly consider less traditional subspecialties and career paths in cardiology, including in HCM, in amyloid, in genetic cardiomyopathies. There is a lot there beyond your classical super fellowship. And finally, thank you for the invitation to talk to you today about HCM. Most and foremost, would like to thank our patients who invest their time and effort to enroll in all these clinical trials. And we have a large team of clinical and research individuals who help us achieve what we are able to achieve every day. So thank you, and I'm happy to answer any questions.
Thank you so very much, Ahmad. That was a great presentation and a great overview of the new therapies in HCM. Any questions from the audience?
Thank you, Dr. Ahmed. This is Talal. I'm one of the Advanced Imaging Fellows. I have a couple of questions. The first one, is there has there any work been done about the utility of repeating cardiac MRI scans, or do you believe that it's just a one-time study for all the patients with suspected or known HCM? For example, if you find that they don't have any LGE on the initial scan, do you repeat that in 2-3 years down the line, or no? That's the first question. The second question is, I just would like to know your opinion on why the ESC guidelines emphasize the obstruction and LVOT gradient, whereas the AHA guidelines don't, when some of the research that you showed demonstrate that with obstruction and gradients, the outcomes are worse.
Thank you. Excellent question. So the first one about LGE, interval imaging for LGE, there have been 3 or 4 papers with good sample size. That's the bottom line. You need good sample size, and showed that the change in LGE amount as measured by gram, is not that much over 2 or 3 years. We're talking about the order of 2 to 4 grams, and so it is there. Our own practice is that we repeat a cardiac MRI for those who don't have devices, who essentially kind of have some risk factors, but are not high risk or exceedingly low risk, we do repeat MRI once every 5 years. Or if there is essentially they're complaining of things that don't fit the clinical pictures much. But in general, we don't repeat it in sooner than 4 to 5 years interval, just because LGE does not progress by that much. The other point is we really don't let patients go symptomatic for a long time unless they choose to have that path. We really are aggressive about you need to feel good, you need to be treated, and if medications are not enough, we need to progress. And once you once you do your interventions, including septal reduction therapies, the value of repeating MRIs might be even less than patients who have obstruction. To your second point about emphasizing, so the guidelines in the end of the day are written by experts, and they have a lot of tendency to essentially achieving consensus. When we talk about sudden death, in general, it does not really appear that LVOT gradient on its own is a major driver. It's combined with the other risk factors, but in its own, it's not a big driver. And so part of the reason is we want everybody, not we, I didn't write the guidelines, but in the community, we want to people to evaluate that risk in everybody, irrespective of just being obstructive versus non-obstructive. However, the guidelines clearly show and talk about how you should evaluate and treat those with obstruction and without separately or differently.
Awesome, thank you.
Any other questions? So actually, Ahmad, I wanted to ask you this question towards the beginning of the talk, but I was waiting for more of our fellows to log in. I've known you since residency, and you've had a very inspirational journey in research, and you're the author of multiple papers with key findings in HCM and amyloidosis. What advice do you have for fellows in terms of planning a career in research?
That's a tough question. So I think it all has to do with the interest of the individual. You have to really work hard in order to try and get to where you wanna be. You have to take sometimes leaps of faith, and you have to understand that you're not gonna get everything in life that you would want. So you have to really be to choose choose your mentors well, choose your colleagues also well. When you're thinking about which path to take, um, uh, try to experiment and try to go through untraditional paths, because you know we tend to play it safe. We tend to follow the usual paths of what everyone else does. But really, if you want to try, to benefit a lot of patients that do not have access to certain specialties, do not have access to certain experiences within cardiology, you might be able to provide that. And I said academically inclined because I truly believe that if you combine your research and clinical interest in the same disease or in the same area, you'll have so much fun. There is complete overlap there, and you will be much stronger. You will essentially have fun doing what you do. But even in private practice and large community settings nowadays, there is a lot. HCM is very common, for example. Amyloid, we're discovering that it's way more common. Also, genetic cardiomyopathies are very common. So you will also have a path and avenue there. So my advice, in summary, is to continue essentially take a leap of faith, try, work hard. There is always luck along the way, and it's always welcome when there is luck that happens. But you really need to create your own luck and try to create the path forward. And you are certainly at the right place. I'm talking to all the fellows; they are certainly at the right place. You have amazing mentors, you have amazing capabilities there. High volume in every disease state, and so you really are already on the right path to achieving what you want to achieve. You just need to be consistent, and you just need to work hard to get to the next step after.
Thank you so much, Ahmad. It's been an honor having you with us today. Thank you so much for this wonderful talk.
All right. Thanks for having me. Have a good day.
You too.